Hello, everyone. Thank you so much for joining us tonight. My name is Molly, and I'm going to be your host for the night. It's right about 7 o'clock, so we're going to get started with tonight's presentation. I am proud to introduce Lynn Oertel. She is a nurse practice specialist for the Anticoagulation Management Service at Massachusetts General Hospital right here in Boston. As the night goes on after the presentation, we will be taking questions. So throughout the broadcast, you can send me questions to the little question box that you'll notice on your screen. All right, welcome, Lynn. Thank you so much for joining us.
Well, thank you, Molly, and I want to thank NATF for this invitation. As you all know, NATF has been a strong advocate and promoter of the patient education, patient awareness about blood clots and how to prevent those and treat those. So I'm glad to have this opportunity to share some of my experience and knowledge over the years. So that's exactly what we're going to talk about today, is being on a blood thinner. And I hope to offer you some insights and advice from an anticoagulation specialist perspective. So I'm just sharing my disclosures. I do occasionally work with either drug or device companies, all related to anticoagulation. And tonight, we're going to be covering four main topic areas. I want to provide to you an overview of available blood thinners. We're going to be focusing on the newer blood thinners that have come onto the market. I want to share with you some important characteristics about these drugs. And importantly, we're going to talk about what are the things that you need to know to most effectively work with your healthcare providers. And we'll close with some tips for safety and protecting you from clotting and bleeding episodes when you're taking these drugs. So here are the 5 new oral anticoagulants that have come onto the market in the last 8 years. And you'll notice that I've given both the generic name and the trade names. And I suspect you probably know the brand names more commonly because you might hear them advertising on the television and in print magazines and so forth. But I do want to mention, though, we have these 5 drugs are all oral drugs, but we shouldn't forget about warfarin or Coumadin. That's been around for about 60 years or so, and many people are still taking that drug. It's still widely used. And I also, other 2 common anticoagulants that you might be familiar with is Lovenox or low molecular weight heparin. That's given by a subcutaneous injection, or intravenous heparin. But we're not going to, for tonight, the purpose of tonight's program, we're going to be talking about these 5 new ones. Oftentimes, collectively, these 5 drugs are referred to as DOACs, and that stands for direct oral anticoagulants. So here are the main reasons why people take blood thinners. First off, if you have a heart condition known as atrial fibrillation or AFib, this is just a different type of heart rhythm that your heart is beating at. And the danger here is that you're at risk, if you have atrial fibrillation, you're at risk for developing a stroke. And this is something we want to prevent, and we can prevent that very well with taking a blood thinner. Another group of patients take these drugs if they've had a blood clot, either in their leg, commonly known as a deep vein thrombosis or DVT, or if the blood clot lands in their lungs, it's referred to as a pulmonary embolus or PE. And then another group of patients, here we want to prevent blood clots from forming in patients that have had hip or knee replacement surgery. Now, the DOACs are not indicated for patients who have a mechanical heart valve, also patients that have rheumatic heart disease, and that's something important to keep in mind. And so in those cases, we probably would go back to using warfarin. So what do blood thinners do? Well, a blood thinner is another way of saying this is an anticoagulant. It simply prevents clots from forming or treats existing blood clots. So on the right here, you can see here is looking inside a blood vessel, so to speak, and you can see the blood cell, the red cells, moving through the vessel. If a blood clot or a thrombus forms, you can see how it impinges or prevents clear blood from moving safely through the blood, and that could either give rise, a small piece of this thrombus could break off, causing an embolus, and that could travel to an organ such as your brain or your heart or your lungs, or also then we have diminished blood flow moving through here, and this is what we want to avoid. So now let's move through and talk about the DOAC drugs. So I'm going to talk to you about them in the order that they were approved by the FDA for use here in the United States. And I'm going to give you a brief overview of each of these drugs. And the first one that we're going to talk about is Pradaxa, which is the brand name, or the generic name is dabigatran. And you can see what these capsules look like, 3 different strengths. They all look alike, so that's important if you can get your glasses out and read those little numbers so you know the milligram strength of those tablets. But there's some important things that are important to remember about this drug. It must be kept in the original bottle. You can't use a little pill box for this medicine. It's recommended that you take it with a full glass of water. You can't open these capsules. You can't crush or chew these capsules. They must be swallowed whole. The manufacturer recommends that you use the bottle within 120 days of opening, and the reason is these capsules and the drug inside is very susceptible to moisture. So there's a special portion of this cap here, as well in these foil-wrapped capsules that keep the drug safe and remove it from the environment. So that's why we say once you open that bottle up, you should take your pill out, tightly close your bottle, and you should use all the contents within 120 days of opening that bottle. These individual blister packs are available. They're not commonly stocked by your pharmacy, but if you ask your pharmacy if this is something you would prefer to take, so you can see as in this example here, we've written Sunday, AM and PM, Monday, AM and PM doses, if that will help you remember to take your drugs. This is something that you could ask your pharmacy, and it certainly doesn't cost anything more to get it provided in this fashion. So this drug is used for patients that have atrial fibrillation. It can be used to treat or prevent DVT or PE, or for preventing blood clots from developing after hip surgery. Notice for atrial fibrillation, this is a twice-a-day drug. Furthermore, the dose of this drug can be modified by how well kidneys work. If you're taking it for DVT or PE, again, it's twice daily, but after about a week of being on a parenteral agent, and that's referring to a drug like low molecular weight heparin or IV heparin. If you're taking this for preventing a blood clot after hip surgery, it's a once daily drug. So I'm going to be going through this type of a schedule with all of the drugs, but what's important, what I want you to see is that each of these drugs has very specific dose patterns. Some are twice a day and some are once a day. So that's very important details that it's important to know about. Rivaroxaban, or Oertel is the brand name, is the next drug that came onto the market. It's recommended that if you're taking the 20 milligram dose or the 15 milligram dose, you should take those pills with food. It's better absorbed that way into your bloodstream. This drug can be crushed and placed in water or applesauce if someone has difficulty swallowing, or if you have a feeding tube. What's nice with this drug is that it comes in this, it's also available as a starter pack. And the starter pack is specifically designed for patients that have had a blood clot, because the dosing for blood clots, for treating a blood clot, is quite different. If we're talking about patients who have atrial fibrillation, This drug is taken once a day with food. Once again, the dose is modified or should be modified if there's some level of kidney disease. As I was talking before, for preventing or treating DVT or PE, for the first 21 days, it's a twice daily drug. And then after that, it's once a day. Okay? This pill pack or the starter pack over here that I was mentioning is very helpful because once you open it up, all the pills are in little plastic windows that you can pop out. So it gives all the doses for twice a day for the first 21 days, and then once a day for the last for the next week following. So it's very easy to keep track of that. It also can be used for preventing blood clots following hip and knee surgery, and once daily. And notice when drugs are used for treating for preventing blood clots after hip or knee surgery, it's generally for a very short period of time. So that's primarily during the immediate surgical and recovery period. And after that, people should be up and around and moving, and that's one of the best things you can do to prevent blood clots. The next drug we'll talk about is called Eliquis, and the generic name is apixaban. This drug can be taken with or without food. You can also crush these tablets and place them in water or applesauce if that's helpful for swallowing. For atrial fibrillation, this is now a twice daily dose. Further dose modification depending upon how well kidneys are working, as well as age or weight. So how this dose is determined with apixaban and AF, it's a matter of not only looking at people's kidneys function, but also their age and their weight to determine the dose. It's also used for treating and preventing DVT or PE twice daily for the first 7 days. That's a kind of a lead-in dose, just like rivaroxaban, but in this case, it's only for the first week, and then after that, it's a once-a-day dose. Then twice daily. I'm sorry, that is a major typo, and I thought I caught them all, but that should be right there for apixaban. I apologize. That is a twice-a-day dose, 5 milligrams after those first 7 days. Again, it's also used for DVT prophylaxis after hip and knee surgery at twice daily for the first 35 days. And for hip surgery, 12 days for knee. The manufacturers also provide this. This is something relatively new that just came onto the market, another similar starter pack only used in the setting of patients who are being treated for a blood clot in their leg, DVT, or lung pulmonary embolism. Savasa, or adoxaban, is another drug that came onto the market. And it's probably the first, I would say, you're probably most familiar with Pradaxa and apixaban and Oertel. Savasa came last on the market. It doesn't seem to be as used as frequently or as often as the other drugs, but it's still available in the United States. Similar reasons as the others we've already talked about, primarily atrial fibrillation. This is a once-a-day drug. And then also for the treatment of or prevention of DVT and pulmonary embolism. Notice, just very similar to Pradaxa, this particular drug also requires treatment first with an agent like Lovenox or low molecular weight heparin, and then continuing. Brand new, just last year, is a drug called Bevexia, or Betrixaban is probably what we're always calling it. This is a new oral blood thinner that just came onto the market, and it has a very specific indication for using this drug. It's to be used to prevent blood clots in hospitalized patients with an acute medical illness. So how the rationale, or actually the indication for using this drug, is a little bit different than the others we've already talked about. And we haven't quite seen a lot of use yet but we will see as time goes on. I have to say, sometimes in the Boston area, our Boston hospitals, sometimes they're a little bit slower in the uptake when new drugs come onto the market. But it also is a once-a-day drug, and it's also one of those drugs that you take for only a short term or a short time period. So you would, if you're in the hospital with an acute medical illness, this is an option to prevent a blood clot from developing when you're really ill and in a hospital bed and not up and about and moving around. Also, then it would continue in the very immediate post-hospital time period, again, until you're fully recovered from your illness. So, as you've just heard, some of these drugs can be taken once a day. Some of these drugs you take twice a day. Some of these drugs require an initial treatment with Lovenox or low molecular weight heparin if you have had blood clots in your leg or lungs. Some of these drugs require another dose adjustment if you're taking it, depending upon how well your kidneys work. And although I didn't show this, just to keep the slides a little simple, there are further dose adjustments that might be needed if you're taking a certain other drug at the same time. So it's very, very important to be aware of these differences between each of these drugs because they're not taken all the same in the same fashion. So it's important for you to be aware of these things because you're the person that might need to be taking these, and I think it's important to be aware of these different characteristics and to determine what's important to me. But I want to start out and say and really emphasize that all of the drugs that we've just talked about are very effective, meaning when I say they're effective, they're very good at preventing or treating blood clots. You should have a lot of confidence in that, as well as that they're very safe. And by safety, I'm meaning there's no more and maybe even less bleeding side effects when compared to warfarin. And that's really important to keep in mind because we've been talking about that they're new. Actually, they're not so new anymore since they've been on the market, some of them for almost 8 years. So let's talk a little bit more about some of those characteristics. So one of the unique things about these drugs is that they work very fast. And that means that and at the same time, the effect of the drug goes away very fast. So now adherence becomes very, very important. It's really important to take your pills exactly as prescribed and not to miss any doses. Because if you miss a dose, you're no longer anticoagulated. If you've been told that you have a kidney or liver problem, then it's quite likely that a dose adjustment may be needed for you, or you might need to avoid using that drug altogether. Some of these drugs have important drug-drug interactions. There are very few drug interactions with these drugs as compared to warfarin, which has a whole big laundry list of potential drug-drug interactions. So it's important to keep your provider informed of any changes in your medications, or should anyone tell you that you've developed a kidney or liver problem over time. You have to think about, well, will I really remember to take this drug every day, once a day? And what about a drug that is twice a day? What will you do to make sure you remember to take that drug once in the morning and once in the evening, if that's what you need to do? Some of these drugs have some special instructions about how to take the drug. Some might say, like, for example, with dabigatran, it's recommended that you take it with a glass of water. Some drugs, like rivaroxaban, you should take it with food if you're taking either the 15 or 10 milligram or 20 milligram dose. One of the nicer advantages of these drugs is that there's no routine blood testing that has to be done in order to evaluate whether or not you're taking the right dose. There are no blood tests. The dose is fixed. You take this dose once a day or this dose twice a day. However, we do need to do some routine blood testing on a very infrequent basis, maybe a year or twice a year, primarily to take a look and see how well your kidneys and liver may be doing, as well as a general blood count. One of the questions that I get asked about a lot is the cost, and that is certainly a concern that many people have. We'll talk a little bit more about that in a couple minutes, so I won't say anything more at the time. And then another very common question I get asked is, are there reversal agents available for these drugs? We'll also talk about that in a moment. And then I do want to mention that it's important to think about, because there could have some effect on the absorption of these drugs if you're undergoing bariatric or weight-reducing surgery, or if you should require a feeding tube. So these are things that you want to discuss with your provider first and make plans for that. Okay, what are the things you should be aware of if you miss a dose with one of these drugs? Well, we would say take your regular dose as soon as possible, as soon as you remember that you forgot it, but you never, ever double your dose on your own. You should call your provider about that missed dose. That's really important. It's very important that you don't stop taking this medicine without first speaking to your provider. That puts you at risk for developing a blood clot. Just like missing doses increases the risk for developing a blood clot. So what are some of the things that you can do? One of them is to, try to make a habit. Take your pill at the same time or times of every day so you don't forget. Maybe if you always brush your teeth at the first thing in the morning, maybe that's a good time, perhaps, to take your pills. Use a pill box if you can. But just to remember, if you're using the Bigatran or Pradaxa, you cannot use a pill planner for that particular drug. It has to stay in its original container. I mentioned the cost because that's a common question that I get all the time. So for those of you that might not be aware, if you live in Massachusetts, Massachusetts has more than 20 standalone drug plans under Medicare Part D. But it's very hard sometimes to try to determine when it comes time, what drug plan is best for me. So you can get some free help at Shine. I've given you the website there, or else you can just simply Google Shine and get to their website. They have people that can talk to you on the phone to try to help you save money. And as you can see, Massachusetts residents saved a lot of money. This article was published in 2017, so that was reflecting the amount of money that Massachusetts residents saved in 2016. So that could be very helpful for you. Also, each of these the drug companies have patient financial assistance programs as well. So a lot of this depends on what kind of insurance you have, what your coverage is. So it's always worthwhile to investigate if this is becoming a financial burden for you. I also talked about and said I would come back to it, and that is the question about reversal agents, because I get asked this a lot. So we have a very specific indications for using one of these two reversal agents, and that would be you must have life-threatening or uncontrolled bleeding, or you need emergency surgery or have an urgent procedure done to save your life. So very specific, very narrow indications for using these drugs. They currently have, if you're taking Pradaxa, the reversal agent for Pradaxa is called Praxbind. It was approved a couple years ago. Note that it's administered intravenously. And then just last month, breaking news, if you should be taking Xarelto or Eliquis, Adexanet was approved by the FDA for life-threatening or uncontrolled bleeding. And again, the thing here is that you want to note that you have to be in the hospital. Both of these drugs are given intravenously. You have to be in the hospital and carefully monitored, obviously, if you have life-threatening bleeding in the moment. Now, we've covered an awful lot of details already, so I've prepared a summary to compare some of the characteristics of these anticoagulants, and you can download this table. It's available for you online. There's 2 pages, but you can perhaps that might help summarize all that we've just discussed. So you can see I've also included warfarin on this table for you. So warfarin is taken daily, but every day your doses might be adjusted, or every week, depending upon what a blood test result is. You'll notice that some of these drugs are twice daily or daily. Some of these drugs you can use a pill planner to aid with compliance, but with the Bigatran, you have to keep it in its original container. But there are many similarities, like we recommend that you always tell your provider of any medication changes, including over-the-counter and herbals. Always carry an ID wallet card with you that tells providers or first-time medical responders that you're on an anticoagulant. Report signs and symptoms. So many of these characteristics apply to all of these drugs. So I hope you'll find that helpful. Now, let's turn our attention to talking about what are the things that are important that you should know so that you can have a helpful discussion with your provider about taking this medicine. Well, it's important that your providers know that why you're taking it, and you should know why you're taking this drug, what the drug name is, what the dose is you're taking, and how many times a day you take this. Some medicines interact with this and should not be taken. So that's why it's important to discuss all medicine changes with your provider. It's also important if you should find yourself being, admitted to the hospital or in the emergency room. Again, all the providers that you're seeing need to know the same information. Also, if you're seeing a new doctor or having a dental visit, it's important that they also know you're taking what type of blood thinner. It's important to keep in touch with your healthcare provider, whoever is managing your blood thinning drugs. So sometimes, some of you might have your own doctor who has prescribed this drug, and he or she is monitoring how well you're doing with this. Some of you might be enrolled in an anticoagulation management service or special clinic associated with your hospital. So if that's the case, that's your provider that's managing your blood thinning drugs. So periodically, as I've already mentioned, blood tests need to be done to see how well your kidneys or liver is working. We also like to do a general blood count on a once-a-year basis or so. And again, your anticoag manager, that's either your clinic nurse or pharmacist or your doctor, will tell you when you need to have those blood tests done. We want you to keep your anticoagulation manager informed of any medication changes you've had. If you've been told you need to stop or interrupt your blood thinner for surgery or an upcoming procedure. If you've ever been told you've had liver or kidney problems. If you're going to be traveling for an extended period of time. And we certainly want, if you change your phone number, your emails, all those things are important. Your address to make sure your doctors know how to reach you. Now, sometimes we have to temporarily stop your blood thinner in order to safely proceed with surgery. And this is always a balance of, being at risk for clotting or being at risk for bleeding, okay? So it's important to plan in advance with your anticoagulation manager and the doctor, whoever that is, that's performing the surgery or the procedure. So you have to keep in mind, if you're a surgeon, you don't want to have any extra blood when you're operating, right? So the surgeons would say, oh, no anticoagulants, no blood thinners before the surgery. But on the other hand, if you're a person who has a high risk for developing blood clots, then you need to keep taking your blood thinner for as long as you can before the surgery. And there are many things that we can do. So the important thing is to plan ahead and talk to your doctor about what your plan will do. Now, the very nice thing, one of the nicest advantages with these DOAC drugs is that most patients can safely stop the drug 1 or 2 days before, because remember, these drugs get to work really fast and they stop working really fast. So after 1 or 2 days, the effect of the anticoagulant is totally gone, so it's very safe to do surgery. And generally speaking, we can resume these drugs 1 or 2 days after the surgery as well. But the specific plan for the exact number of days for you to hold and when it's safe to resume for you is something that you need to talk to your doctor about. And always there are a couple of occasions where some patients need to be placed on Lovenox or a low molecular weight heparin just prior to their surgery as well. So sometimes it can get a little more complicated, but the thing is we want you to keep you safe while you're just before you're having surgery, and so that your surgery can be done safely and you're onto a good recovery. Also, special plans need to be clarified if this procedure is going to be involving a spinal or epidural anesthesia, because that also has some implications for bleeding that we want to avoid. Okay? So what can you do to be successful and avoid serious consequences? I think one of the best things is to be informed, just like you're doing tonight, by taking the time to learn a little bit more about these drugs. I want to say, too, and I can appreciate when you're in the hospital and you're being discharged, or even when you go get a new prescription filled at your pharmacy, you're probably given a lot of papers to read. And I can't emphasize enough how important it is to find the time within a couple days to read the information that's on those papers, especially the information about your drugs. If you have questions, please write them down so that you can discuss them with your provider, either at your next visit, make a phone call after if you had a chance to read those papers, and write your questions down as you're reading so that you can review them with your provider. So now let's talk about some of the common side effects. So usually bleeding is the most common side effect, and it's a side effect that can happen with any one of these blood thinners, right? So if you have a minor bleeding complication or a symptom, then most important is to watch it and inform your anticoag provider or your doctor. So you might have a bruise. It might be a small bruise like this. And this is a quarter that you're seeing right there. I'd like to tell my patients how big is the bruise? Is it the size of a quarter? Well, go get one and see if it matches, right? Or is it the size of a dime? Or if it's bigger, is it like a deck of cards? So to be a little more accurate about describing what this bruise looks like. You could have bleeding from a little paper cut or something. Again, with bleeding, if it's minor bleeding like this, I try to remind patients that you have to put firm pressure on that and hold it for 5 or 10 minutes. Look at a clock and time yourself. Holding your finger for 5 or 10 minutes seems like a really long time if you don't have anything else to do. And generally, that's all that's needed. But the bleeding symptoms that we're most concerned about are major bleeding symptoms, and these would require prompt medical attention and evaluation. So here's another bruise, but it's a really big, bad, nasty-looking bruise. Perhaps this person fell. There could be bleeding inside the bony joint right there. That could be very serious. That needs prompt medical attention. Or if you have blood that you're seeing, or your urine turns red, or your stools look like you have blood in your stool, those are important and major symptoms of bleeding and need to be evaluated. This is showing you a little bit of blood inside the head, inside the skull. So bleeding inside the brain or even on top of the brain is very, very important. This often happens after a fall or a head injury. All require prompt medical attention. So commonly, people want to know, well, when do I just get myself to, can my daughter drive me to the emergency room, or do I need to call 911? Do I need to call an ambulance? Well, here are some common symptoms. Most of these symptoms can be attributed to bleeding, but they might be attributed to having a clot developing. So if you are experiencing chest pain, discomfort in your arms, back, neck, or jaw, that's important. Those could be symptoms of a heart attack. They could be symptoms of a pulmonary embolism. If you have trouble breathing, you experience a severe headache, a headache like you've never had before, confusion or numbness in one of your body parts. If your vision suddenly changes, those are all important symptoms of something really significant going on and you need urgent medical help. Call 911. These are common stroke signs, and the American Stroke Association is using this acronym called FAST. F for face drooping, A for arm weakness. I could also say weakness in a leg. S for slurred speech, and T, time matters, time counts. This is, again, a 911 call and says, I think I'm having a stroke, or I think my husband or my wife is having a stroke. If you fall or have an injury to your head, that needs to be evaluated if you're taking a blood thinner. If you're throwing up blood, sometimes it might be bright red, or sometimes it can look like coffee ground material. Or anytime you have bleeding that you simply cannot stop, all reasons to get to the hospital. And I'm not trying to scare anyone out there, but I think it's very important that people know and recognize these so that you know what to do, how to act, what should I do next if any of these should occur. And I might add, the incidence of really dangerous bleeding is extremely low with these drugs. So that's the good news to always remember. Some other safety tips that we can talk about is, I've already mentioned this briefly before, but carry a wallet card that says, I'm taking an anticoagulant. It's really helpful for first responders at the scene to know that. It's also important to keep a list of all the medicines that you take with you. This could be very important information for the medical team that's taking care of you in an emergency. But above all, avoid injury and keep yourself safe. And if you're engaging in things like bike riding or whatever, wear a helmet, wear your seatbelt. If you're outside working in the yard, wear eye protection, wear work gloves when you're working with sharp tools. And those kinds of things can also reduce the opportunities for any dangerous bleeding. At home, we want you to prevent falls. We're all getting older and our bones are getting brittler, so we don't want to fall. And we don't want to fall and certainly hit our head. So look around your house, remove those hazards, clear clutter from the stairs, remove scatter rugs or electrical extension cords. Use safety devices if you need them. Use walkers or canes to help you safely walk around if you're a little unsteady on your feet. If you're getting up at night to use the bathroom, use a night light so you can see where you're going and making sure the coast is clear. And as I've already emphasized tonight, is that we want you to take your blood thinner exactly as prescribed. It's been estimated that 50% of patients don't take their medicine as prescribed. That's being called you're non-adherent. You're not following the rules, so to speak, and it can contribute to your death. If you don't take your medicine after leaving the hospital, you're more likely to end up back in the hospital, and that's certainly what we want to prevent. So here are some tips for medication adherence. So some of these things I've already talked about, but write it down. That will help you. Or make a chart that shows what medicines you have to take. If you can use a pill box, use it to get organized. Make sure your refills come on time and you don't run out of the drug before so take a look to see how many pills are left in that bottle and request your refills with a couple weeks or two to have it to prevent times when you would run out. Make it a habit. Take it at the same time every day so you don't forget. Set a reminder. If you use a smartphone or you have an electronic alarm, set it to remind you to take your pill at night. And most importantly, ask questions when you have them. That's very important. I'm showing you two very helpful online resources that you might find helpful. You can find lots of patient information on the North American Thrombosis Forum. The National Blood Clot Alliance also has a great deal of patient information, not only about drugs, but also about various medical diseases. So you might find both of those resources helpful for you. And I'm going to close and just simply say, drugs don't work in patients who don't take them. And that was a quote by a former Surgeon General in the United States. So thank you very much, and I'll be happy to take your questions now.
Thank you so much, Lynn. That was wonderful and very informative. We do have quite a few questions, so let's get started. Our first person was wondering, they said that they have been on warfarin for a year and a half due to a DVT and thrombophlebitis. They asked, if I were to switch to another medication, how would I know if my INR level is in the normal range if it doesn't require a monthly blood test?
So that's a very good question. I get asked that all the time. And we have lots of patients. I've had lots of patients who have been previously on warfarin and they want to transition or switch to one of these new drugs. So one of the advantages with these new drugs is there isn't any blood testing associated with them. So there's no more INRs to go for. Getting an INR is only necessary when you're taking warfarin. There are no blood tests for determining the dose for these new drugs. They're either this dose once a day or this dose twice a day, and that's how they work. That's how they were designed to work.
Very interesting. And the same person wanted to know, if you're discontinuing someone on warfarin, is it tapered off generally, or can it be stopped all at once?
So that's a question that gets asked regularly, and I have to say, over my many years, I've heard various prominent hematologists give different opinions on that. So I have generally not tapered off of warfarin. If someone has completed, so remember, sometimes people take warfarin to treat a blood clot, but they only have to treat the blood clot for a period of, let's say, 3 or 6 months. So they're on warfarin, they're getting their INRs, they're having their doses monitored and maybe adjusted over time. And then when the end date is here, if all is set, then you just simply stop your warfarin when your doctor or your anticoag nurse tells you to do so.
Right. Very interesting. And along the same lines, because we did get a few questions about warfarin, another patient who's been on it for 4 years has been told by a friend who's an ER doctor that they should move away from warfarin because the DOACs are better in terms of risk profile if an accident happened. They want to know, are the DOACs better in general over warfarin in terms of preventing a future clot outside of the bleeding risk due to an accident? And how does one decide to go off warfarin and make that switch to a DOAC?
So several very good questions there. Let me tackle the first one about the first issue, and that was around safety with the DOAC. So I have to say, warfarin is a blood thinner, and all of these new DOACs are blood thinners. So all of them have the same risk, that is bleeding, okay? Some of the large clinical trials, this was scientific randomized trials with thousands and thousands of patients worldwide to study these drugs. One of the things they found is that all these drugs worked, for the most part, just as well as warfarin, okay? Because we've had warfarin now for over 60 years. It's like that's the gold standard by how we take care of many of our patients who have atrial fibrillation or a blood clot, okay? On the other hand, we also want to know, are these new drugs just as safe or safer than warfarin? Most of the time, these drugs are just as safe, and occasionally they might have been safer because the times that an intracranial, a really bad bleed in the head, an intracranial hemorrhage. The number of times that occurred in the patients taking these new drugs was less than the patients taking warfarin. So I think that's what a lot of people remember about these clinical trials, is that the incidence of bleeding, intracranial bleeding, was a little bit lower than it was in the warfarin patients. So that's an important characteristic. It certainly is something important to remember. However, I have to say, if you're in an accident, and God forbid, a terrible automobile accident, and you get a lot of soft tissue injury, you're going to bleed. You're going to have bleeding. You're going to have bleeding internally. And I don't think it makes a difference if you're in a bad accident, if it's warfarin or if it's one of these drugs. Now, on the other hand, these drugs, remember, the action goes away pretty quickly. So if you are taking a drug like rivaroxaban, for example, that's the Oertel, that drug is taken once a day. If you take your pill at 7 o'clock in the morning with your morning breakfast, that's okay. And if you should happen to have the misfortune of being in an automobile accident that evening, well, the effect of that drug is going away 12 hours later, right? That's not the case with warfarin, all right? Warfarin has a very, very long half-life when compared to these new drugs. So did I cover all the points there with that question?
Yes, and one other quick question about warfarin. Someone wanted to know what participants should do if they've been missed a dose of the warfarin, and does the half-life, like the longer half-life, affect its safety profile?
So anytime you miss a drug with an important blood thinner, so all these drugs are very important, they're all blood thinners, you should always let any prescription med, if you find that you're missing your drugs, you need to let your doctor know about it, all right? Because you come into the doctor's office and you're supposed to be taking your blood pressure pill once a day, maybe you have 2 blood pressure pills. And if your blood pressure is off, is it because you're not taking your pills, or you need to have an increase in dose in your pill? And the same thing with warfarin. If you've missed a day, it's important to let your provider know. So the provider then, next time you have your blood test, depending upon how soon that blood test is, we know better how to interpret the results of that INR. So if I'm looking at a low INR today, and I would want to know if that patient forgot 2 nights of his warfarin last week, because that might explain why it's low today. So therefore, it might do more harm to increase that dose. I would rather know and hear from my patient to say, oh, jeepers, Lynn, I forgot. I went away on the weekend and I forgot to bring my pills with me and I didn't take my warfarin. And if I'm looking at that, I'd say, okay, thanks, Joe. I really need it. That's really helpful for me to know. I'm not going to change your weekly dose. Maybe I might elect to give Joe a slight boost for a day or 2. But then if I'm looking at his records, I might think, well, the dose that he's on is the right dose for him, provided he takes it. Okay, and I think the same is true with the DOACs. It's really, perhaps it's even more important with the DOACs because their half-life is so short when compared to warfarin, so that if you forget to take, if you go away for the weekend and you forget to bring your pills, when you come back home Sunday night, you're not anticoagulated. You're not protecting yourself from either developing a blood clot or treating the blood clot that you may have if you've had a recent DVT or pulmonary embolism. So it's really important to talk to your provider about these things, because that's all part of maybe making the right decision about which one of these blood thinners is the best blood thinner to suit you the most. So all these things become very important details.
Wonderful. Thank you so much. The next question we have, a few people who have asked about the best time of the day to take Xarelto. One person mentioned that, considering the half-life of the medication and the normal variation of risk factors over the course of the day, such as, stasis during sleep, they asked, could you please just discuss the pros and cons of taking this medication in the evening versus in the morning, or half in the morning and half in the evening?
Well, let's see, a lot going on with that question. Very interesting. So, Xarelto is a once-a-day drug, okay? It's important to take this drug with food. That's the important aspect, okay? And I've had several conversations with the scientists, with the manufacturers, and because if you read the label, the formal FDA instructions for this medicine, it will say take your 20 milligram dose daily with the evening meal. The only reason it says evening meal is because that's how the clinical trials were done, and that was the design, and they wanted all their patients to take it with the evening meal. I've had many, many discussions, and the key thing is to take it with food. So, I know some people that don't eat a very heavy meal at night. They have their biggest meal in the middle of the day. And it's like, if that's the time you remember to take your Xarelto, that's okay with me, because it is important to take it with food and not when you go to bed on an empty stomach for absorption. To be honest, I have not ever heard anything about nighttime absorption when you're sleeping, about the effect of that at all with these drugs. I think it's important that it's taken on a regular basis, on approximately the same time every day, and go forward. And Xarelto is a drug that's a once daily drug, so you don't take half the pill in the morning and half the pill in the evening. You take the whole pill in the morning or the whole pill in the evening.
Thank you. And then along the same lines, a patient asked about kind of the idea that's changing right now, that you could use a lower dose of Xarelto, moving to the 10 milligram per day versus the 20 milligram per day.
Very good question. So both Xarelto and Eliquis, and this is for patients who have had a DVT or pulmonary embolism. Both of these drugs have an even reduced dose that can be used after at least 6 months of standard treatment. So what I mean by that, let's talk about Xarelto first. If you develop a DVT or a pulmonary embolism and you land in the hospital, you see your doctor, and you have your studies done, and you have a discussion about drug therapy, and the choice is Xarelto. You begin taking Xarelto 15 milligrams twice a day with food for the first 21 days. After that, beginning on day 22, your dose is 20 milligrams once a day with food for the remaining treatment period. When the 6-month mark comes along, there's the option. You have to have it's important that this is discussed with your provider to further reduce the dose to a 10 milligram daily dose. For long-term treatment or prevention, we want to prevent the recurrence of another blood clot from developing. So that's the rationale for some people that have had a DVT or a pulmonary embolism. It's depending upon the circumstances, they might have some sort of a genetic or inherited blood disorder that puts them at risk for having another blood clot. And these people need to be on anticoagulants or a blood thinner, could be for the rest of their lives, to prevent that. So here Oertel and Eliquis both have an even lower dose, both relatively new onto the market, but that's an option provided there's been at least 6 months of standard anticoagulation treatment.
Very interesting. Thank you for sharing that. We've gotten a lot of questions about how long people should be on blood thinners. A lot of patients have received some mixed information about if they should be on it for lifetime. Other doctors have told them that, that's not necessary. Could you talk about that? And then could you also just mention kind of what the long-term side effects of being on these medications for life might look like? And does that contribute to any sort of liver or kidney damage?
Okay, good question once again. So let's talk about patients that have atrial fibrillation. So atrial fibrillation generally is a heart disorder that one might develop as they get older. So as we're getting older, folks, sometimes this is something we can't avoid. It's something, though, that shouldn't change your life. There's no reason why you can't go on and have a happy, wonderful life. But the thing with atrial fibrillation is it puts you at a very high risk for developing a blood clot that's going to land in the brain and cause a devastating stroke. And that's what we want to prevent. So most of the time, if you have atrial fibrillation, meaning your heart is going in and out of this abnormal heart rhythm, your clot risk doesn't go away. All right, you're going to have that for the rest of your life. So therefore, we want to treat you with a blood thinner also for the rest of your life. Okay? Same story or similar story with patients that have had a DVT or a pulmonary embolism, and there are other risk factors involved. And those other risk factors could be things like having a blood coagulopathy or a blood clotting disorder that puts you at risk for further blood clotting. Blood clots can be fatal. There are many Americans that die. More Americans die every year in this country from a DVT or pulmonary embolism than those that die collectively in automobile accidents, AIDS, or breast cancer. And that oftentimes is something that people don't appreciate. So this is a very serious condition, and we want to prevent that. And that might mean having to take a blood thinner for the rest of your life. So being on a blood thinner for the rest of your life means it has to be something that has to be reviewed and evaluated. Sometimes some people develop more risks for bleeding. The bleeding risk is higher than the clotting risk. So sometimes those patients, we just simply can't keep them on anticoagulants because the risk of bleeding gets too high as things might change, medical conditions change over time. So these are things that, you have to have regular evaluations and discussions with your doctor about. The comment about, or the question about, will these drugs cause kidney or liver damage? I'm not aware that happens. What I'm saying when I talk about kidney and liver function or problems, if your kidneys and livers are used to get drugs out of our bodies, essentially, very simply. So if your kidneys don't work really well, it might take them longer to clear or to move the drug out of your bloodstream. So therefore, you might need a lower dose. And that's a very simple way of trying to explain this. But the people that develop kidney or liver problems over time, they might need less of the drug to make it still work just as well as it should. Okay? Because there'll still be enough in the bloodstream. But I don't think it's
wonderful.
Yep, okay.
Mm-hmm. Oh, I'm sorry. I didn't mean to cut you off. We had another person ask, are these drugs approved for people with PAI1?
PAI1. PAI1. I am blanking on that. PAI. one. I am blanking on what that acronym means.
Oh, well, if whoever sent in that question would like to just send me a quick description perhaps of what it is. And in the meantime, Lynn, would you just tell us, does the quantity of water or other fluid intakes affect people's risk of clotting effectiveness on the DOACs?
Was the question about clotting? Does drinking water affect clotting effectiveness?
Yeah, so does the quantity of water that someone drinks affect their risk of clotting or the effectiveness of the drug they might be on?
Okay, I get it. So no, it doesn't. The amount of water you drink does not affect the effectiveness of the drug. But on the other hand, as you might have read, if you were ever in the airplane and you're reading the page in the magazine that talks about preventing blood clots when you're flying on airplanes, it talks about staying well hydrated. And it also probably says avoid drinking excessive amounts of alcohol, because alcohol actually will dehydrate you. So drinking, keeping yourself hydrated, moving around, those are, eating good diets, all healthy things, all common sense type things are all good things to do to prevent blood clots from forming.
Wonderful. Thank you for answering that. And then I did find out the PAI-1 is a plasminogen activator inhibitor.
Okay, so whoever asked that question, that's a very good question, because how was that question asked, Molly? In what context?
So they wanted to know, are these approved for people with this PAI-1? And then she also asked, or said that when she was on warfarin 5 years ago, it was the only blood thinner approved for people with PAI-1.
Okay, so that's very helpful. Thank you for writing in to clarify that. So I don't have a lot of experience with that. My memory is that the new DOAC drugs have very specific and very limited indications for use as compared to warfarin. So we use warfarin for many types of problems and many other problems besides atrial fibrillation or venous thromboembolism. So I would, although I am not personally have any true working experience with PAI-1, I would say that's another discussion that I would refer to her doctor and her specialists in that area. But to my knowledge, they are not approved for use with that condition.
Thank you. And a patient who is a kidney donor and has a remaining kidney that has slight moderate impairment is on apixaban for a current DVT, and they also have an IVC filter. She wanted to know if it's correct that apixaban appears to be better and has the least effect on kidneys.
Good question. I'll take the having one kidney doesn't impact the decision about using these drugs. It's how well that kidney is working, and I'm sure with that person, her kidney function tests are regularly monitored over the course of every year. So, and then the aspect about is apixaban so. There's a lot of new and I would say somewhat new data. There's been new analyses, new looks at this, and some might say that apixaban is a better choice for use in patients that have kidney disease. All of these drugs have cautions around avoiding use when kidney function gets really, really poor. I can say both Eliquis and Oertel have approved indications for use with patients that are on hemodialysis. The data on that is very, very small numbers of human subjects were included in those studies. And I would say a great deal of caution should be used. And I think this is another area of further study and that we will learn more as time goes on. And then there was one other aspect of that question, Molly. What was the last part that I wanted to speak to?
I think they just wanted to know if apixaban was DOAC-wise the least harmful for people on kidneys. Or sorry,
yeah, I don't know that
with bad kidneys.
Yeah, I don't know that I would say it's least harmful. It might be there's some studies that would suggest that perhaps it has kidney function. This gets complicated, but I think those are discussions you can have with your provider. I think all of these drugs have very specific parameters around kidney function, and we're using, for the most part, it's a formula essentially to determine kidney function, and so that needs to be calculated and evaluated and assessed. And what does this mean? And I think that there could be some favoritism towards apixaban, but I think we got to be careful about making that a broad brush straight statement.
Great, thank you. And then the last question that we're going to be able to fit in for the night, someone was just wondering, the role that aspirin might play compared to that low-dose Eliquis we had talked to earlier. The person wants to know, for people who might need to be on a blood thinner for life, is there any data about the effectiveness of the aspirin?
Very good question. So I can say, and I probably should have talked a little bit about aspirin, because aspirin is it's not an anticoagulant, it's an antiplatelet. So it affects the platelets that are in our bloodstream, and platelets are very important molecules to make blood clots, okay? So it's sometimes referred to as a blood thinner, but it works in a very different way than these other drugs that I've been talking about. So the question so if you're on an aspirin, it should be, and you're taking any blood thinner, whether it's warfarin or one of these DOACs, that should be carefully discussed with your doctor, because it does add another risk for potentially developing bleeding. So there are many patients, though, that have cardiac conditions that it's important for them to be on perhaps a baby aspirin a day. And they're also on a blood thinner. And if that's been discussed with your cardiologist, your doctor, that's perfectly fine. Now, the question about whether or not aspirin works as well, like we talked about these really low doses of rivaroxaban or that's Oertel or Eliquis, it does not. Simply put, there were several studies that have been done in the past looking at warfarin and comparing that to aspirin in patients to prevent recurrent blood clots in the legs from developing. That was not a favorable trial. It did not show a benefit. So I would say, in generally, no, it won't be as effective. However, there are some caveats with that, because every patient brings with him or her their own unique set of medical problems, etc. So there are people who develop medical problems or medical diagnoses over time that, once again, at some point in time, someone might say, gee, the risk of keeping you on a blood thinner is high because of X, Y, or Z. However, maybe an aspirin will offer you some protection. Okay, so there are cases where that might happen. I do want to emphasize, for the patients that have atrial fibrillation, the recommendations from the American Heart Association, the American College of Cardiology, and other very prestigious societies around the globe will say, if you have a risk score, so there's some very specific risk scores that actually predict, so to speak, your risk of developing a stroke. And if this risk score number is 2 or higher, then you should be treated with an anticoagulant, a blood thinner, to prevent blood clots. If your risk score is 0 or 1, then perhaps aspirin is reasonable for further reducing your low risk already. So I hope I've clarified that.
Yes, that was wonderful. Well, Lynn, thank you so much for taking all of these questions. If we did not get to your question, I do apologize. You can feel free to reach out to the NATF team at info@natfonline.org. That's our email address. Our next online support group will be held on July 10th. Our host will be Dr. Gregory Piazza from Brigham and Women's Hospital, who will give a presentation back to the basics. What are blood clots and how do they form? Thank you, everyone, for joining us tonight. And once again, Lynn, thank you so much for taking this time out of your day to really share all this information with us.
Well, thank you, Molly. It's been a pleasure of mine. I've really enjoyed this time with everyone, and I wish everyone good health and a happy future.
Have a good night, everyone.